Welcome back to the deep dive. We are doing something a little specific today. Usually we cast a pretty wide net, but today I really want to focus on a group of listeners who are um, quite literally the central nervous system of the healthcare world.
Right.
If you are a nursing student, or maybe you're already deep in the trenches of your clinical rotations, this conversation is specifically tailored for you.
It is. And honestly, even if you aren't in nursing, maybe you're a patient, which, let's face it, we all are eventually. The psychology we're going to unpack today applies to pretty much every human interaction.
Yeah, that's a good point.
But the stakes in a hospital, they're just so much higher. We aren't talking about awkward silences at a dinner party. We're talking about life, death, and those, incredibly vulnerable moments in between.
Absolutely. We were looking at a stack of research on interpersonal and gendered communication in healthcare. And look, I get it. I know what your life is like right now. You're memorizing pharmacology. You're learning how to start an IV without making someone scream.
Yeah.
You're trying to remember the difference between respiratory and metabolic acidosis. The technical stuff is just, it's overwhelming.
Right. And because the technical skills are so demanding and so terrifyingly concrete, I mean, you either hit the vein or you don't, it's very easy to look at a topic like communication and think,
Oh, the soft stuff.
okay, that's the soft stuff. I know how to talk to people. I've been talking since I was 2. I'll be fine.
Exactly. It's the I talk to my friends, I talk to the barista, I'm good mentality. But our mission today is to decode why talking in a hospital is a completely different beast. We're going to unpack why communication competence, that's the term the literature uses, is actually just as vital to patient outcomes as knowing your anatomy.
We're going to talk about why patients lie to you, and they do lie constantly. We'll look at why they physically cannot hear a word you say after a bad diagnosis and how your body language might be screaming, "I don't care," even when your mouth is saying, "I'm here to help."
So let's start with that big picture before we get into the nitty-gritty. The source material centers on this idea of communication competence. It sounds a bit academic. What are we actually defining here?
At its simplest level, communication competence is the ability to effectively exchange and process information.
Okay.
But in healthcare, we have to look at the context. This isn't just data transfer. It's not, uploading a file from one brain to another. It's interpersonal.
The research draws a really interesting distinction here between what they call everyday relationships and interpersonal clinical relationships. They use this barista versus the nurse analogy, which I thought was brilliant.
This is such a great way to frame it. Think about your local coffee shop. You might have a barista you see every single morning.
Yeah, they know your name, they know your order.
Exactly. Oat milk latte, extra hot. It's a pleasant interaction. It feels like a relationship. You smile, you chat about the weather. But, and here is the key, if that barista quits tomorrow and is replaced by someone else who also knows how to make a latte, does your life fundamentally change?
Not really. No. I might miss the banter or maybe the specific way they drew the little foam art, but I still get my coffee, my day goes on, the caffeine hits the same.
Exactly. That is a transactional relationship. It's interchangeable.
Right.
But now, switch that to a healthcare setting. If you're a patient and you've built a bond with a nurse who understands your pain tolerance, who knows your family history, who you trust with your vulnerability, and suddenly that nurse is replaced.
Panic. It feels like a loss of safety. It feels like I have to start the entire story over from scratch.
Absolute panic, because a provider-patient relationship is built on shared goals. The goal is your health, your survival. It requires specific rules like confidentiality, and it requires mutual work. It is not interchangeable.
The nurse isn't just a caffeine delivery system.
No, they are a partner in the outcome.
So for the nursing students listening,
Yes.
you are not the barista. You aren't just delivering a service. You are entering a partnership where your specific presence, your personality, and your communication style actually change the outcome.
Precisely. And that partnership relies on navigating some pretty intense barriers. And the first one we need to tackle is the one we take for granted the most, the actual words we use.
Let's get into section 1 then. Verbal competence. Now, you'd think, I speak English, the patient speaks English, we're good. But the data in our source material regarding literacy is, honestly, it's shocking. I had to read it twice to make sure I wasn't seeing things.
It is startling, and it's something we often gloss over in higher education. We have to look at the literacy gap. If you're a nursing student, you're on track for a bachelor's degree, or you already have one. You are highly educated. You've been assimilated into this culture of complex medical terminology.
You speak medical, You know what ambulatory means without thinking about it. You know what PRN means. You know what idiopathic means.
You speak medical fluently, it becomes your native tongue, but your patience. The source cites statistics from the Department of Education that they're tough to swallow. More than 30 million Americans cannot read effectively.
30 million. That's roughly the population of Texas. That's not a fringe group. That's a massive chunk of the
A
population.
huge chunk. And it gets more specific to health there. Nearly 50% of adults cannot understand a prescription label.
Half.
Half. Think about that. Take 2 tablets twice daily with food. Half the population might struggle to parse exactly what that means in practice. Nearly 20% of high school graduates, people with a diploma, cannot read effectively.
So when you, as a nurse, are standing at the bedside, rattling off instructions about discharge or complex medication schedules or potential side effects.
There is a coin flip chance that the person staring back at you has no idea what you are saying. But here's the kicker. They're too ashamed to admit it.
Oh, yeah.
That is the first layer of noise in the system. The language barrier isn't always foreign languages. Sometimes it's just literacy. They will nod, they will smile, and they will go home and take the medication wrong because they couldn't read the bottle.
It creates this dangerous illusion of competence. You think you did your job because you said the words and they nodded. But no communication actually happened.
Exactly, and even if they do understand the words physically, the words might not mean what you think they mean. This brings us to the concept of denotative versus connotative meaning. I found this distinction fascinating because it explains so many misunderstandings.
Let's break that down.
This is so crucial for clinical practice. Denotative meaning is the dictionary definition. It's objective. It's just the facts.
Right.
Connotative meaning is the emotional baggage, the subjective history attached to the word.
The example the text gives is the word cancer. And this is such a heavy, loaded word.
Right. So let's play this out. You're a provider. You get a pathology report back for a patient. It says carcinoma in situ, or stage 0. Denotatively, strictly medically, this is fantastic news.
Best case scenario.
It's the best case scenario for a cancer diagnosis. It's non-invasive. It hasn't spread. It's often completely curable with a minor procedure.
So you walk in smiling. You might even feel relieved because you were worried it was going to be worse. You say, good news, we found some cancer cells, but it's stage 0.
And to you, that's a win. But to the patient, they hear the word cancer, and their brain doesn't go to the textbook definition of in situ. It goes to the connotative meaning. Maybe cancer means that's what killed grandma.
Or chemo.
Maybe it means chemotherapy. Maybe it means pain or bankruptcy or death.
And suddenly the interaction is broken. You're smiling about a cure, and they are planning their funeral.
Completely broken. The moment that word hits the air, the patient experiences an emotional flood. We call this noise.
Let's unpack noise. Because usually when I think of noise in a hospital, I think of alarms beeping, carts rolling down the hall, or people paging doctors overhead.
That's physical noise. And that's problem 2. Hospitals are notoriously loud. But in communication theory, noise is anything that interferes with the message. And emotional noise is the loudest thing in the room.
The source used the breast lump scenario to illustrate this.
Imagine a patient finds a lump in the shower. From the moment they find it until the moment they see you, which could be weeks, they have been living in terror. They are imagining the worst. By the time they are sitting on the exam table, their internal anxiety is so loud that they physically cannot process new information.
It's like when you've just gone through a breakup and you're sitting in a lecture hall. The professor's talking, the acoustics are fine, you're looking right at them, but you aren't hearing a thing.
Exactly. That is distraction as noise. So for the nursing student, the lesson is you cannot just transmit data. You have to check for reception. You have to realize that if a patient is terrified, their auditory processing is shut down.
You have to bridge the gap.
You have to bridge that gap. You have to ask, what does that word mean to you? Or tell me what you just heard. You have to bridge the gap between your dictionary definition and their emotional reality.
Which leads us to active listening. The text is pretty critical of the modern clinical environment here. It seems like technology, which is supposed to help, is actually getting in the way.
It's the computer problem. You have probably seen this as a patient. You walk into a room and the provider is staring at a screen, typing away, asking questions without looking up. Does it hurt when you breathe? Click, clack, clack. How long have you had the fever? Click, clack, clack.
It feels like they're treating the computer, not the patient. It feels like I'm just data points being entered into a spreadsheet. Like I have an inconvenience to the data entry process.
They're focused on the algorithm. I need to fill these boxes to bill correctly. But the source gives some very actionable tips here. First, wait to type. Let the patient finish their sentence.
That seems so hard when you're in a rush, though. The efficiency pressure in hospitals is insane. Nurses are running ragged.
It is hard. Of course it is. But think about the cost of not doing it. If you type while they talk, you signal that the data entry is more important than their story. You might miss the subtle hesitation in their voice that tells you the real problem. Second, eye contact. And third, provide feedback. Restate what they said. It proves you were listening, and it clears up that denotative, connotative confusion we talked about.
So if the patient says, I'm worried about the test, you don't just say, it'll be fine. You say, it sounds like you're anxious about what the results might show.
Exactly. Validate the emotion. Clear the noise. It takes 10 seconds, but it saves hours of misunderstanding later.
Okay, so that's the verbal side. But the source material makes a huge claim in the next section. It says that in American culture, if the verbal message and the nonverbal message contradict each other, the receiver will almost always believe the nonverbal one.
Every single time. We are wired to trust body language over words. Evolutionarily, words are new. Body language is ancient. If I say, I'm really interested in your problem, but I'm checking my watch, tapping my foot, and looking at the door.
You don't believe my words. You believe my foot.
You believe the foot 100%.
This brings us to the doorknob scenario.
This is such a classic hospital moment, and it creates so much frustration. It's painful because we've all done it or had it done to us. The provider is ready to leave. They walk to the door. They put their hand on the metal doorknob, turn their body halfway out into the hallway, and then over their shoulder they ask,
You got any questions?
all right. And the verbal message is, I am open to questions. But the nonverbal message is, I am leaving. I am literally halfway out the door. Please do not stop me.
And the patient stays silent.
They stay silent, not because they don't have questions, they probably have a dozen, but because they have been told non-verbally that there isn't time. They feel the pressure to be a good patient and not be a burden, so they go home confused and outcomes suffer.
Let's break down the different categories of nonverbal communication, because for a nurse, your body is a major tool. The text lists a few. Proxemics, haptics, kinesics. Let's start with proxemics. This is about space.
Edward Hall's research on space is standard social science, but it applies so uniquely here. We have zones. Social space is 4 to 12 feet. That's where you stand at a party or talking to a clerk. Personal space is 2 to 4 feet. That's for friends. And then you have intimate space, which is 0 to 18 inches.
Intimate space is for lovers, maybe your mom, maybe your child. It's the whisper zone. It's highly protected real estate.
Right, and nurses.
Nurses live in the intimate zone.
They live there. You're listening to heart sounds. You're checking pupils. You're starting lines. You're inserting catheters. You are constantly in that 0 to 18-inch bubble with complete strangers.
Yeah.
And the text calls this the invasion of nursing. Because socially, it is an invasion. We do it so casually because it's our job that we forget how aggressive it actually is to a stranger. To the patient, you are a stranger invading their most private zone.
So what's the fix?
The best practice here is incredibly simple but often overlooked. Ask permission. It changes the dynamic entirely. Is it all right if I pull my chair closer? I need to listen to your heart. Is it okay if I step in? It restores a tiny bit of control to the patient. It acknowledges, I know I am entering your protected space, and I respect it. It stops being an invasion and starts being a collaboration.
That connects directly to haptics or touch. The text uses the bus analogy, which I loved. It's so visceral.
It is. So imagine you are riding the bus to work. You're reading a book. A stranger walks up to you, doesn't say a word, grabs your wrist, and starts counting your pulse.
I'd scream. I'd probably try to punch them. I'd call the police.
Of course, because it's assault. It's a violation. But in a hospital, we do the bus behavior constantly. We walk in, grab a wrist, check a pulse, drop the wrist, and leave. We touch without asking. We treat the body like an object, like a piece of furniture we are inspecting.
The blood draw example was even more intense. Tying a tourniquet and stabbing a vein is painful. Doing it without asking permission first signals that the data, the blood sample, is more important than the patient's bodily autonomy.
That's the core message. When you touch without asking, what we call instrumental touch, you're saying, my need for this medical data supersedes your right to your own body.
Wow. Okay, that's a heavy perspective shift.
It is. And look, obviously in an emergency, you act. If they're coding, you don't ask to do chest compressions, you save the life.
Of course.
But most healthcare isn't a code. It's routine. And in the routine, that permission asking builds the trust you need for the hard stuff later. It transforms the touch from an assault into a caregiving act. It reminds the patient that they are a participant, not a specimen.
Let's move to kinesics. This is body movement and gaze. There's a scenario in the text about a spinal tap that really highlights how patients are basically human lie detectors.
Oh, yeah. The scenario is this. A patient is terrified of a spinal tap. She asks, does it hurt? The provider looks away, bites their lip, shifts their weight, and says, not really.
Oof, the lip bite. That's a dead giveaway.
The lip bite, the breaking of eye contact, those are universal signals of deception or discomfort. We call them leakage cues. The patient analyzes that instantly. She doesn't think, oh, he's just nervous. She thinks, he's lying. This is going to be agony.
And now her anxiety spikes, her muscles tense up, and because she is tense, the procedure actually does become harder and more painful.
Right. It's a self-fulfilling prophecy.
All because the nonverbal cues signaled deception.
Exactly. It would have been better to maintain eye contact and say, it will be uncomfortable, there will be pressure, but I will talk you through every step. That matches the verbal and nonverbal. It builds trust. It tells the patient, I'm telling you the truth, even if it's not what you want to hear. Trust is more important than comfort in that moment.
We also have to talk about artifacts.
Yeah.
This is what we wear and what it communicates. And I have to bring up the pink party pants example from the text because, well, it paints a picture that is hard to forget.
It's a hilarious example, but it makes the point perfectly. A student wears pink sweatpants that say party across the rear end. She's just going to class. She isn't intending to send a message to her elderly professor walking behind her.
She's not inviting him to a party.
No. But the artifact, the pants, communicates a message regardless of her intent. In the hospital, your artifacts are screaming messages. The white coat says authority. The scrubs say, I'm ready to work. The stethoscope around the neck says, I have the knowledge.
What about tattoos and piercings? The text mentions this is subjective. I know a lot of nursing students have ink now.
It is highly subjective and generational. To one patient, a full sleeve of tattoos might look cool and relatable. It might make you seem human. To another, maybe an older patient, it might signal unprofessionalism, or even, and the text mentions this specifically, a fear of hepatitis risk.
Really? They see ink and think disease.
It's a generational association. Needles, tattoos, blood-borne pathogens. It's noise again. If the patient is staring at your eyebrow ring wondering if it's infected, they aren't listening to your discharge instructions. You have to be aware of what your appearance is saying before you even open your mouth. It doesn't mean you can't have them, but you need to be aware of the noise they might create.
And body weight was another artifact mentioned. This one is uncomfortable, but real.
It's the contradiction issue. If a provider who is visibly obese tells a patient they need to lose weight to be healthy, there is cognitive dissonance. The artifact, the body, contradicts the verbal message, lose weight. It creates a credibility gap.
Right.
It doesn't mean the medical advice is wrong, the advice is scientifically sound, but the delivery system is compromised.
The last nonverbal category is chronemics. Time.
Time is power. It's that simple. In almost every culture, the important person makes the less important person wait.
The boss doesn't wait for the employee. The employee waits for the boss. The fan waits for the rock star.
Right. Now look at the patient experience. They are often paying for the service. They are anxious. They're often naked or in a flimsy gown, and they wait. They wait in the lobby. They wait in the triage. They wait in the exam room for 45 minutes with no update.
It reinforces a paternalistic dynamic. My time as the provider is valuable. Your time as the patient is not.
It does. It reinforces that you are the subject and they are the object. And recognizing that power imbalance is the first step to fixing it. Even just apologizing for the wait can rebalance the scales a little bit. I'm so sorry I kept you waiting. It acknowledges their humanity. It says, I know your time matters too.
Okay, let's shift gears to section 3. This is a big one, and it's nuanced. Gendered communication. First off, we need to clarify the definitions the source uses. Sex versus gender.
Very important distinction. The text defines sex as biological anatomy, chromosomes, hormones, male and female.
Okay.
Gender is a social construction. It's behavioral. It's how you identify and how you act.
The key takeaway being, you cannot determine someone's communication style just by looking at their anatomy.
Exactly. Just because a nurse is male doesn't mean he communicates in a masculine style. And just because a doctor is female doesn't mean she uses a feminine style.
The text briefly touches on how we develop these styles, biological theories about brain structure, social learning, where we mimic our parents. But what I found most useful for the nursing students is the breakdown of the styles themselves. masculine versus feminine styles.
And remember, these are labels for styles, not strict rules for men and women. Think of them as tools in a toolkit. The masculine style is generally characterized by a focus on independence, status, and control.
This is report talk. Just give me the facts.
Right. It's direct, it's competitive, it's more likely to interrupt, to gain control of the conversation. It's solution-oriented. Here is the problem, here is the fix. It's very linear.
And the feminine style.
This is focused on relationship maintenance, rapport, nurturing, collaboration. It's less about establishing status and more about building a connection.
So more questions.
It uses more questions. It seeks consensus. How do we feel about this?
So clinical application time. If I'm a nurse, which one is better? Is the feminine style better because it's nicer?
It's not about better. It's about appropriateness. The text argues for adaptability. You need to be bilingual in these styles.
Give me an example of when you'd need the masculine style.
Okay, there's a fire in the hospital wing, or a patient is coding. Do you want your nurse to use a feminine style? How are we all feeling about the smoke? Let's collaborate on an exit strategy. Does anyone have any ideas?
No, I want them to scream, everyone out now. You, grab the chart. You, move the bed.
Exactly. A crisis requires masculine directness. Status and control save lives in a fire. You need a commander. You don't need a debate. But let's say you are trying to convince a terrified patient to agree to a difficult treatment plan, or you're breaking bad news.
If you come in barking orders, then they might shut down.
Right, that requires the feminine style. Building trust, listening, collaborating. We are in this together. How do you feel about this option? The competent nurse can switch between these styles based on what the patient needs, not what the nurse naturally prefers.
That is such a crucial skill, reading the room and shifting gears.
It is role competence. You are playing a role that the context demands. If you are naturally a soft communicator, you need to learn to bark orders for emergencies. If you are naturally direct, you need to learn to slow down and listen for the bedside. It's about being versatile.
This leads us into the final section, which is about the unique, almost weird nature of the relationship itself. Section 4, the paradox of self-disclosure.
This is one of those things you don't notice until it's pointed out, and then you realize how bizarre the medical relationship is. In normal life, friendship is based on reciprocity.
You tell me a secret, I tell you a secret.
Right. If I tell you about my divorce and you just stare at me and say nothing, that's weird. That's uncomfortable. If you tell me about your struggles, we bond. We are equal.
But in the clinic,
It is a one-way street. The patient is expected to reveal everything: sexual history, illegal drug use, abortions, fears, bowel movements, things they haven't told their spouse.
and the provider.
Reveals nothing. You don't tell them about your divorce. You don't tell them who you voted for. You don't tell them your fears. You are a vault.
It's the naked reality, literally. The patient is often physically exposed, vulnerable, naked. The provider is clothed, in a uniform, protected.
It creates a massive imbalance. The patient is giving up all their privacy to a stranger who is giving up none. That is psychologically difficult. It borders on voyeurism if not handled correctly. The patient can feel exposed and judged.
So how does a student manage that? You can't just start telling patients your personal secrets to make it fair. Hey, I see you have a rash. Well, let me tell you about my rash.
No, absolutely not.
No.
Boundaries are important. You aren't friends. The text advises a few things to manage this tension. First, acknowledge the difficulty. It's okay to say, I know these are personal questions, but I'm asking because. Explain the why.
So it's not just curiosity.
Exactly. Make it clear it's for their health goal. I need to know about your drug use so I don't give you a medication that reacts badly with it. Second, ensure confidentiality. Remind them that this stays in the vault. And third, use empathic listening.
Which is defined as?
Supporting the listener without evaluating them. If they admit to heroin use, you don't grimace, you don't judge, you listen to understand. Because you cannot offer your own secrets to balance the scale, you have to work double time on empathy to make them feel safe. You have to be a safe container for their secrets.
It really highlights how much work the communication is. It's not just chatting. It's a strategic set of behaviors designed to bridge a massive gap in power and vulnerability.
That is the perfect summary. It is work. It is a clinical skill, just like inserting a catheter or titrating a drip. It requires practice.
So we've covered a lot of ground today. We moved from the medical jargon barrier and the literacy stats, 30 million people, to the silent power of body language.
We talked about how you stand, how you touch, and how you look, how the lip bite can ruin a procedure.
We navigated the personal space of the patient, realizing that nurses are professional invaders of privacy, and we broke down those gendered styles. moving beyond male-female to look at directness versus collaboration.
And we landed on the paradox of the relationship itself. The demand for total honesty from the patient, while the provider remains a professional cipher.
It all comes back to that barista versus nurse idea. This isn't a transaction. It's a relationship with high stakes.
The takeaway for me is that role competence means choosing to be collaborative. It's so easy to be authoritarian in a hospital. The system is designed for it. The uniform, the schedule, the knowledge, it all gives you power. Communication competence is about how you choose to share that power.
I want to leave our listeners, especially the students heading into their next shift, with a final thought to chew on.
Hear it.
Next time you walk into a patient's room, look at the scene. The computer's asking you to fill out check boxes, the clock is ticking, the patient is maybe crying, or maybe they're just silent.
The pressure is on to fix the problem.
Right. Do you try to fix it with a medical algorithm immediately? Do you hide behind the computer screen? Or do you use the silence? Do you sit down, change your proxemics, and let them tell you why they are crying?
That's the challenge.
In a system designed to treat diseases, ask yourself, are you communicating with the body on the bed? Or are you communicating with the person inside it?
That's the difference between a technician and a healer.
Thanks for diving deep with us today. Good luck on those shifts.
Take care.